we as a routine do bilateral ICL implants, that means in one sitting. And so far we have done 3 patients, 6 eyes in the last 3 months, and the results have been pretty good. Only thing is that we have been a little selective in our initial choice of the Viva because Viva is an EDOF lens, and it says that it gives you an ad of about 1.25. So, for our initial experience, we chose people who had a myopia of -5 or more, and who were in the age group of 45 to 55, who were just having a near ad of about 1.25 to 1.5. And with that, we started an experience on this new series of lenses. And we found that actually we got about an ad of +1 in all of them. And because they were having an ad of 1.25, so the patients were extremely happy. Why we chose the very high myopes, 5 and above, and not routine e-metropes with the near vision problem, was that e-metrop is very comfortable with his distance sharp vision. And an EDOF lens is naturally going to make some difference as it spreads the focus. We also weren't keen on trying out this lens on a person who had a myopia of -1, -2, because these people are very comfortable with their near vision without glasses. They have a very sharp near vision. So they may also not immediately accept a spread of the focus as would happen in any EDOF. So that is why our range of choice for initial trials was over -5 diopters. Anybody who has a good vision for distance and an ad of about 1.25. So this patient today also had a similar circumstances, and let me show you the data of this patient. So in the right eye, the PMT was 12.25 with an ad of 0.75, and in the left eye it was 11.5 with an ad of 0.5. Now, for all those people who are using an ICL, the star ICL, we know that whatever is the spectacle power, usually we need to add 1 to that figure to have the ICL power. So when we did the right eye, which was 12.25, we used a power of anything between 13 and 13.5, right? So we did, I think, 13.5. And now that we have this left eye, 11.5 with half a cylinder, we would ideally be using, add this to this makes it 12, add 1 makes it 13. So the lens would be anything between 12.5 and 13. So we used an IOL of 12. And why did we use an IOL of 12 is we were targeting micro-monovision. So the right eye target is 0, the left eye target is -0.75, and the plan is micro-monovision. So essentially it is more about planning. The surgery is essentially still the same.
Sanjay, what's the age of the patient?
The age of the patient is 53.
So you've added it's like a double whammy. You have a presbyopic correction in the lens, and plus you also made micro-monovision.
Yeah, because our old experience tells us that we get an ad of about +1 with all those 6 eyes. So we, and the patient, when we were trying to explain this to the patient was very keen that will I be able to see for distance and near. So we had to tell her that this is an ad of +1. So you would be seeing intermediate. You may have a little problem in near. So she said, no, but I also want to have near. If I have come all that way and I'm spending so much or whatever, I'm not talking about the commercials. I want a vision for distance and I want a vision for near. So we had to explain her micro-monovision. She understood the concept, and that is how we did it. So can I have the video, please? So first thing, an ICL Viva ICL looks exactly the same as a normal ICL. Its calculations, its size, shape, uh, insertion technique stays exactly the same. In fact, when you look at the lens, you can't even make out whether it is a Viva lens or a regular ICL. There is only one point in the lens by which you can make out that this is a Viva lens. And that is for all those people who have used a regular ICL, you would remember that in a regular ICL, there is a hole in the right leading haptic and a hole in the left trailing haptic, right? So in this Vivo lens, they made a partial thickness hole near the left leading haptic. And that is the only indication that can tell you that this is an EDOF lens. It is a refractive lens, it is not a diffractive lens.
So that's the difference actually. It's on the left leading haptic.
See.
Hole in the left leading haptic. Otherwise, it's in ICLs. It's on the right side on the leading haptic. No.
No, wait. It also has a hole in the right leading haptic and the left trailing haptic. That is common to all ICLs.
Yeah.
Along with this, close to the left leading haptic, that means in the main body, not in the haptic area, they made a partial thickness hole, not a full thickness.
Okay.
Just a partial thickness hole to identify that this is an EDOF lens.
Okay.
So if you see this on the left side, just near the haptic edge, you can see a small hole, but I don't think it's very clear right now. Maybe let me see if it gets better now. Wait, let it go into the eye, then I'll show you. You can see that better. Now, the technique is the same. I would again emphasize, when most of the people use an ICL, they find loading the ICL a big problem. And like always, I'm explaining here to you how to load. So this fork-tipped applicator, this can turn clockwise or anti-clockwise. And if I attach it to the tip and I turn it clockwise, then the haptic edge will turn anti-clockwise like a gear. So not in the center, a little in front of the center. Here I press, turn it clockwise and see the plate turning anti-clockwise and getting into the groove of this injector cartridge. So insertion is very easy. Just follow the simple step. I've seen a lot of doctors doing this now, so I'm happy that this technique is catching on. Now you have to see that these three holes, center, one in front, one behind, they are aligned in one linear line. If they are aligned in one linear line, especially when the ICL is pulled in the nozzle, then you are sure that this ICL will behave well when it opens up. It will open flat, parallel to the lens and will not touch the lens. It is also said that if the lens is moving to the right or the left and then opening up, then you can always twist your hand to the right or the left to compensate for it. But still, somewhere it has the propensity to touch the crystalline lens. So what I do is, if I see the lens opening up sideways, I just pull out that lens with the cartridge, reinsert it. Now if you see, you can see all the three holes. Of course, they are not exactly in the center, but they are visible from the surface. 1, 2, 3. So now I know that this lens will open the way I want it to open. Loading it. So this is a second very important point. Now check in your cartridge whether the 3 holes can be seen. Just can be seen. They may be a little laterally displaced, but they should be seen. If they are seen, then there is very little reason to worry as you inject the ICL into the eye. Now, my favorite technique, I do hydro insertion. Why hydro insertion? It is fast, minimum visco used, so less turnover of fluid within the eye to remove that visco later on, less haze of the cornea, faster surgery, more crystal clear cornea day 1, no rise of early IOP because visco was hardly used. So we have never had, now see, I've injected it 2/3 in. The ICL is opening the way it should be. This is the perfect position, so I can plunge it further. At this stage, I can also pull it out if I'm not sure it is not coming out well. 2/3 in is the point to decide whether this is going to go in or you have to pull it back. If it is going to go in, okay, here you go. It goes there and opens out the way you want it to. Now you can see hardly 1-2 strands of the visco. Just 1-2 strands, which were only there in the injector cartridge, which just come out in about 5-10 seconds with an IA system. And that's it. The ICL is now over the iris, and all we have to do is tuck in. Now, Vivo ICLs are only spherical ICLs at the moment. They are not toric. So that is a restriction right now. We can only choose patients which are spherical or within half a cylinder. And then now we are tucking it under hydro. Okay, 1 in. 2 in. 3rd in. And the 4th in. That's it. The surgery is over. Now you just need to hydrate the edges, and ICL is so simple. So normally in my routine practice, it takes between 4 and 5 minutes to do one ICL.
So
And
when you do
sorry.
a bilateral ICL, how do you space it? I mean, do you do it immediately, or you do it after a few hours, or you do it on a different table with a different instruments or with a different nursing staff?
We do it on a different table, and we take it to the second OT and do it.
And do you space it? I mean, is it a couple of hours or is it 1 hour, or it's just
No, we do it in a continuity. By the time the patient is shifted to the second OT and prepared, I do another case in the first OT. Then I go over to second OT and do it. And then from there the patient moves out.
That was really nice, Chaudhary. I also these days prefer, for the last few months, I've been doing hydroimplantation in most of the cases. Unless the pupil is very small, then it's better to inject viscoelastic and then do it. And plus, additional advantage of hydroimplantation is that while tucking the foot plate, you can direct the fluid in that side, on that side. Then the moment you bring the foot plate, it immediately goes behind the iris.
Goes under the iris, yes.
So that is one advantage. The only thing is that sometimes the pupil is slightly on the smaller side, then there is a little bit of struggle. That's the only thing. Wherein I prefer using viscoelastic. Very nicely shown. Only thing is that something that you would like to tell the people, like it is always said that when you are implanting an ICL, you must ensure that the hole on the leading haptic is on the right side. Now you have a hole on the left side as well. So
in a Vivo.
In a Vivo, in a Evo Viva.
Evo Viva, yeah. And that is also partial thickness.
Yeah. So,
but that is not exactly in the haptic. That is more towards the main body. So that is the difference. So it's not actually a thing for confusion.
So far you have done 6 eyes, as you said?
Yeah. So today we did 2, so that was 8 now.
8. Okay.
How are the results in those 6 eyes?
Ma'am, in all of them we got a consistent result of +1 ad. So as per the claim, it was supposed to be 1.25. In one patient, we got 0.75 ad, and in all the other 5, we got an ad of +1.
Okay, so that is
In
why you
either-
are doing micro, I mean, you undercorrected by 0.7.
Yeah, so by that concept, we said if it has happened consistently in all these cases, and this patient was a little fussy, so we decided to place our bets on a micro-monovision.
That was very nicely demonstrated. Yeah.
So what about the patients, like you've done these patients here, but I'm sure other people and other surgeons have also done it too. They also do some kind of a micro-monovision if you talk to them, or it's...
Now, I think right now probably another 2 or 3 have been done. How many have been done so far? Viva? Other than me? 2 patients. 2 patients. One was done with Shri Ganesh, doctor, and the other one was?
Okay.
Okay. I think it was only Dr. Shri Ganesh who was done.
Nobody has done it. And
Nobody else has done it.
when you order these lenses, how easy it is? I mean, what is the time that they take?
The same time, 15
same
days.
time. 15 days
15
it's
days.
available.
Yeah.
But these days, spherical lenses, they give it fast. Even within a week, they give it. But for toric, they take 15 days time.
Spherical they will get even in 3 days. Now,
3
because
days, yeah.
it's easy to maintain an inventory of a spherical.
Yeah.
It's a limited inventory.
Yeah,
When it comes to toric, the inventory becomes very big.
true, very true.
So that is why they keep those powers which are running powers, but those extreme powers, I think they import every time.
Have you worked on the quality of vision of these patients?
And
Yes.
you had a study on the quality of vision, ICL versus LASIK.
Yeah, ICL versus Smile,
Smile.
I had done quality of vision. And quality of vision in ICL was better than Smile. And that is understandable because since you're working in the cornea, but you just want to see whether it actually happens or not. So, but I just wanted to know whether the quality of vision, because of this EDOF thing coming up,
Contrast and
any effect on any induced
Out
aberration?
of the 3 patients, we checked out. Naturally, we were very keen to record and document everything.
Yeah.
2 patients, the vision was very nice, very clear.
Okay.
And in one patient, he could not see the near as clearly or the distance as clearly as he thought he could. But the last line was visible, but it was not that crisp visible as he was having with glasses before. But he could see 6:6. So we believe that there's a little drop in the contrast. But that is only one patient, one eye.
some people like to pilocarpinize the pupil at the end of the surgery. So would you use pilocarpine and when would you use it if you had to?
I, as a routine, put in a drop. Why? Because once you put in an ICL, the AC has become very shallow for the iris. And the moment you hydrate, in lot many people, the iris tends to jump out. So if you just put in a wee bit of carbachol or pilocarpine and stretch the iris and make it taut, the chances of it coming out is less. And if it is clogging at the angles, it will separate from there. Yeah. So I, as a routine, put a little bit. It's so little that usually patients don't complain of headaches.
So next day also the patient feels more happy because it's a smaller pupil rather than dilated pupil.
And do you put
Visual acuity results.
cycloplegics also after the surgery?
No, nothing.
Don't need.
I think we
No,
all
we
don't
should-
use cycloplegic.
We should not, because there are a couple of reports of Viret Zawali after use of cycloplegics.
Especially because the space is less.
Nee, we have had Viret Zawali even without
Even
cycloplegia.
without, even without it, you can have cycloplegic.
In fact, we have had about 7 cases of Viret Zawali.
That was being, thousands
But
of-
if you are not doing the hydroimplantation and you are injecting viscoelastomes, See, actually, because if you doing the implantation with the viscoelastic, it's never like not remove complete visco. That is 100% sure with the ICL. Some of the viscoelastic is definitely remains there.
Especially
And
under the ICL.
these cases post-operatively, I've seen some of the cases showing anti-chamber reaction. And what about these cases? Then what do you do in these cases? Now you are doing hydro implantation, but when you were doing the visco implantation, then
See, when we're doing visco implantation, removing the visco from in front of the iris is always easy. The problem is what is behind the ICL
Yeah.
and what is trapped in the foot plates of the ICL.
yeah,
Right? It is what is trapped in the foot plates of the ICL that keeps coming up later.
yeah.
You stop the irrigation aspiration, you bring out the two cannula, and you'll suddenly see visco coming in from the periphery towards the center under the hole and coming up like a smoke stag, you know. So, and it keeps coming out, it keeps coming out, it keeps coming out. So visco is probably not the way to go. Sooner or later people will change using visco.
The only condition wherein I would prefer visco is wherein I have to do a little bit more of rotation in toric ICLs, because see, these are all placed, and studies have shown that vast majority of these foot plates are placed either on the ciliary body on one side or on the zonules, etc. So the risk of zonular damage is there when you are rotating a lot. So maybe a visco cushion will be useful in these cases. But in vast majority, you hardly require 2-3 degrees or 5 degrees of rotation. So in such cases, you can very easily manage with hydro. That's what I feel.
Plus, you know what? If you have to rotate, we just don't simply rotate. We kind of with the manipulator tuck it forward, move it to the side, and release. Tuck it, move it to the side, and release at a certain angle. So slowly we rotate it. A dynamic rotation, the haptics will get entangled in the zonules, and that could cause a problem.
So thank you, Sanjay. I think we've had a great session, and many congratulations for the life surgery, near life surgery from your center. And I think we'll move on to the next session now, and I'm sure Vivo is here to stay, and we will have a lot more data, lot more cases by next year. Thank you so much.
Thank you, Dr. Namrata. Thank you, Dr. Rajesh. Thank you, Dr. Rajesh Prasad.